Transverse plus posterior wall fracture through the Kocher-Langenbeck approach. For the transverse plus posterior wall fracture fixation, the patient is placed in a prone position, that is, face down. The surgeon stands lateral to the patient. The head is in this direction, the foot is in this direction. On the model, we will reflect the gluteus maximus muscle posteriorly. Then place a retractor into the lesser sciatic notch beneath the obturator internus muscle. This retracts that muscle, plus it retracts the sciatic nerve. We have to be careful with tension on the sciatic nerve. Another retractor can also be used in the greater notch in front of the piriformis muscle. And often, another retractor with the tip driven into the iliac wing to retract the abductor muscles. This now provides exposure of the retroacetabular surface from the ischial tuberosity to the inferior ilium. The hip capsule is seen here, which can be opened for access to the joint. Through the greater sciatic notch, we get access to the quadrilateral surface, the inner wall of the pelvis, and also to the pelvic brim and anterior column. There is a limited access for palpation to assess the reduction, or sometimes even to place a reduction clamp through the greater notch to the pelvic brim and anterior column. For this exercise, we'll use part of the 3.5 instrument set and this selection from the 4.5 set. These are the instruments used for the insertion of the 6 mm Schanz screw. Also needed this pelvic reduction forceps used with screws. The fragments are held in place with the small oblique pelvic reduction forceps and the bone holding rod, both with pointed ball tips. The template serves as a model for bending the plate with the bending pliers for reconstruction plates and the bending iron. Place the pelvis in the vise as if the patient were in the prone position. Seen on the close-up is a transverse plus posterior wall fracture with a posterior wall fragment remaining attached to the hip capsule. This injury typically is associated with a posterior dislocation of the femoral head. During the surgical approach, a free bone fragment of cancellous bone, covered partially by articular cartilage, was found in the wound. This fragment must be included in the final reconstruction. The first step will be reduction of the transverse fracture and lag screw fixation. Following this, the posterior wall will be reduced and plate internal fixation across both fractures will complete the fixation. The pelvic reduction forceps will be used for reduction of the transverse fracture. A 4.5 mm cortical screw is placed into the retroacetabular surface just lateral to the ischial spine. The 3.2 mm drill bit is used and a screw 10 mm longer than the measured depth is inserted. Another 4.5 mm cortical reduction screw will be placed into the inferior ilium at a point anterior to where the lag screw will be placed across the transverse fracture. The hole is drilled with the 3.2 mm bit, and once again a screw 10 mm longer than the measured depth is inserted. The reduction forceps are attached to the screws. The correct orientation of the reduction forceps prevents a stretch injury to the sciatic nerve. If the forceps are placed in the opposite manner, a stretch injury to the sciatic nerve can occur. However, we'll use this orientation for the video in order to increase visualization. The screws are not completely tightened, so that the bone fragments may rotate underneath the reduction forceps. We will now attempt to reduce the transverse fracture. The reduction appears perfect as visualized at the greater sciatic notch and the retroacetabular surface. Palpation through the greater sciatic notch, however, reveals a step along the quadrilateral surface and pelvic brim. Distraction of the femoral head from the joint also reveals a step in the articular surface. This malreduction of the acetabulum is due to rotation of the lower ischiopubic segment. A 4.5 millimeter hole is placed in the groove between the posterior rim of the acetabulum and the ischial tuberosity. A 6 millimeter shank screw is inserted into this hole. The transverse fracture will now be reduced by controlling the rotation of the ischiopubic fragment with the shank screw and the displacement with the pelvic reduction forceps, which are then locked. This maneuver may not be adequate to hold the reduction, and additionally, the small angled jaw clamp with ball tips can be inserted through the greater sciatic notch with one tip on the quadrilateral surface of the ischiopubic fragment near the pelvic brim. Palpation of the obturator canal through the greater sciatic notch is an aid in directing a lag screw across the transverse fracture towards the anterior column. The lag screw hole is started with a 3.5 millimeter drill bit at the level of the greater sciatic notch, but lateral to it. The screw is directed towards the superior pubic ramus. The femoral head is distracted during drilling to visualize the joint and avoid joint penetration. The 2.5 millimeter drill bit is used to complete the threaded hole. The drill bit is seen to exit near the pectineal eminence. An ideal direction of the drill bit that follows the axis of the anterior column is not possible through the Kocher-Langenbeck approach. The depth is checked and a 3.5 millimeter cortical screw inserted. A second 3.5 millimeter cortical lag screw is inserted near the border of the greater sciatic notch and just above the transverse fracture site. The 2.5 millimeter drill bit exits the bone on the quadrilateral surface of the ischiopubic segment. After length measurement, insertion of the lag screw. After removal of the pelvic reduction forceps and the shank screw, the articular reduction can be checked by distraction of the femoral head with the traction table. The femoral head is reduced again into the joint with the release of traction, and the posterior wall is reconstructed, beginning with the free fragment of cancellous bone and cartilage. This fragment will be held in place by the overlying posterior wall fragments. The posterior wall fragments attached to the hip capsule are now reduced into position and held with the ball spike and at times a periosteal elevator. These fragments will be fixed in place with a 3.5 millimeter cortical lag screw. A 3.5 millimeter gliding hole is drilled into the fragment, followed by placement of the 2.5 millimeter threaded hole. With the patient in a prone position, a horizontal orientation of the drill bit will direct the drill clear of the joint. The depth is measured and the screw inserted. Repeat this procedure for the second screw. A straight 3.5 reconstruction plate will be placed from the ischial tuberosity to the inferior ilium. The plate will be curved so that the curve roughly parallels the posterior rim of the acetabulum. The 3.5 bending template is contoured to the posterior column. It's seen that the plate is slightly under-contoured as compared to the template. The plate is initially fixed with a screw into the concavity, just above the superior pole of the ischial tuberosity. A 2.5 millimeter hole is drilled, the length measured, and the 3.5 millimeter cortical screw inserted, though not completely tightened. Final positioning of the plate is performed. A drill hole is placed at the proximal extremity of the most proximal plate hole in order to achieve a compression effect. Final tightening of these plate screws completes the final bending of the upper portion of the plate and ensures that the plate applies pressure to the posterior wall fragments and is tensioned over them. The distal screw is directed distally into the ischium. Another screw is placed proximally. The joint capsule is normally left attached to the posterior wall fragments to preserve vascularity and hip stability. For the exercise, we'll open the capsule to visualize our reduction.